you place the implant, you have no idea how the restoration is going to be, and you do it later. It can create a challenge for the lab, I'll tell you. The future is now. You need a 3D clear view of the area of surgery, and when you weigh the risk of failure, the risk of injury, the risk of loss, the fact that you are not seeing a clear anatomy of the surgical site where you are placing the implant. You look at that, this gives clear view of the surgical site. This is similar to what you get on a PA. Similar to what you get on a PA. But this section you never get on a PA. This section you never get on a PA. And so having a 3D is the standard of care when you are doing an implant. As a matter of rule for me, no 3D, no implant. End of story. I don't compromise on that. So you should. And of course, you then end up matching the two. The bottom line of the requirements, you see the yellow up here is the model which has been matched with the 3D. The yellow is the model which has been scanned, either an impression taken, a polyvinyl siloxane impression, Imprigam, not alginate, because we are talking millimeters here, millimeter dentistry. If you don't believe or can't practice millimeter dentistry, you shouldn't be placing implants. Okay? So with that impression margin, you can make a surgical guide for this patient, because you have the crown having been designed on the model the way you want it to be. Then you design your implant placement, like we'll see later in the lecture, to pass through the center of the occlusion of this crown so that you can place it, and then you can end up with your crown. You will see at the very end, one of the cases that we did, immediately the patient walked in, we did the implant, we had designed the crown, we had milled the crown, and we placed the implant, and immediately we restored it. The patient walked out, she couldn't believe the smile she had at that time, that it could all be done in one go. So it's very possible. Now, to mix and match these two, the model and the 3D, you need specific software. This is where you differentiate between the men and the boys. The Sirona system is the only system which can mix and merge the CAD/CAM data of the impression with a 3D to be able to design a surgical guide, all on one platform, and even mill it or 3D print it. Fine, you have other 3Ds which have come on the market, and so you need another software to merge the two. And you'll have to pay every time you use that merging software to merge the two. That's the difference. So with the Sirona, you pay once and you can do it forever and ever, or you use a diagnostic software. We'll look at the other tools that you need, which obviously is a surgical kit, which is dependent on the implant system. The digital workflow, how does it flow? It is very simple. I summarized it there, but you scan the patient, both the X-ray and the impression, the model, either the model which is taken in the mouth. For instance, what you can do, if you're not able to send the patient to Pan Dental to have a free scanning inside the mouth, you can take your impression and send the impression, and we'll scan it for you and digitalize it for you at no charge for the next 3 months, okay? Or you can do it yourself if you can acquire, if you do have access to other ways of doing it. So you have your two dimensions, both the 3D scan and the impression taken, then they are merged, and you do a virtual planning. you do a treatment plan. So there's a bit of back and forth between the lab, you, and the patient, and say, this is what we are proposing to do. Then at the end of it all, you make a surgical guide, mail it or print it, and you're given the surgical guide, then you place it. And it takes you 15 minutes normally to do it. Of course, in the interest of time, I'm going to rush through some of the slides. This is the setup of what you do, how you do it. Basically, 3D, you try and make sure there are no artifacts, a good resolution. So you need a very, very good quality 3D image to give you good quality view of the bone. And some situations to prevent, you do open bite, you ask the patient to push back their tongue, soft tissue separation, etc., etc. And you get a DICOM file. With the DICOM file here, you would want to see the full jaw. In this particular case, what you get from the 3D, you should be able to see some of the soft tissue, like you see here. The tongue is here, okay? And you can then plan. Of course, in some situations, you have a situation where no soft tissue separation, no tongue, so it is not a good one. So there are a few key points when you want to have a good planning to be done. So the scanning is done. Now you gather the cone beam, the intraoral scan, they're inside the software, the merging software. One of the softwares we are introducing to make life easy for our colleagues who have different 3D imaging machines, like Vertex, etc. You can send the 3D images to us. We'll merge the two for you using co-diagnostics, the new software which we are going to be implementing to make it easier for you. So in this software, which merges these two, the cone beam and the intraoral scan, showing the defect here of the missing tooth, we match up and we do the wax up, which is the tooth that you're going to be replacing. And you can do it for the front teeth, especially very, very, very prudent, very important. Same here, you have the two merging, you have the missing tooth or the broken tooth or the tooth which is going to be extracted, and you have the cross-sectional view. And so what ends up being done when you merge the surface scan, you see here the model. This is the yellow is the model of the physical model, and the gray is the 3D X-ray image, both being merged, okay? And so you see the soft tissue outline here in all the cross sections, okay, as well, because they're important. They are part of what covers. So you have the wax up here of the tooth you want to place. So because we have the wax up here, you can see it here. You plan to have your implant in this direction. So you can have a screw retained implant, which is the standard of care. If you can make your implant screw retained, believe you me, that ugly hole is your easiest hole, is your best hole out of a very difficult situation when you come to the maintenance. It makes your maintenance much easier, quicker, simpler, easier. So imagine this is your model with the wax up here, implant is planned, and the screw access hole is here. You place the surgical guide and plan to do the implant here. Of course, you can rotate the implant with the tools in the software, whatever direction you want. And that's basically what you do. So you've done virtual planning, and it makes your life simple. So you review between the dentist, the lab which is making the surgical guide, to make sure you are all on the same page. And the lab at that point will tell you, in the implant position, you may have a defect, you have a physical structure you have to be careful about, you are near the sinus, or you're gonna be near the incisive canal. Let's move the implant this way, this is the way to go, so that you don't move things far out of line. That is very, very key, to make sure you are digitally communicating with the lab the finer details. If there's going to be need of grafting, how much defect there is, the lab can tell you. And these days, they can even 3D print the bone graft to fill a defect, so that you just plug it in. So we have fully customized designs, get rid of undercuts, and then you have a fully customized guided design here. Here, you see the design. There are different designs for the surgical guides with crossbars here to stabilize this surgical guide. Sometimes you can make them cross to make sure the guide is retained. The guide in this case is retained on the teeth neighboring. So if you don't have teeth, you have to have anchor pins here on the sides, on the palate, to anchor and hold your surgical guide. Okay? Different designs, either for flap or flapless, and then you 3D print them. Okay? So your surgical guide is made here. Okay? And you can even design your, customize your healing abutment like we did for that particular case, or you use a temporary abutment and the lab then designs it. Okay? Now, this is again, a bit, in the interest of time, it summarizes some of the things I've been talking about, the cone beam, what you need, the form of DICOM data. It's going to be available. You can look at it later. STL files, standing for surface tessellation language, that's the file format. For the plaster model that you get, you have a plaster model here, and you scan them. We have a model scanner to scan and digitalize all your models at no charge. Like I said, Richard is on hand to do it for you at no charge for the next 2 months. Or there are different extraoral scanners, intraoral scanners that are available in the market. They produce an STL file. That's what we need, an STL file of this. Okay? In core diagnostics, this is one of the softwares we're introducing to be able to receive other 3D images. It costs money to have this core diagnostic software. You import both files, the 3D data in core diagnostics. Once you import it, you import the 3D, the model, you merge the two, and then you design virtual plan. You design the crowns. You see the crown, and you design the crowns the way you expect them to be in occlusion. So ideally, you should have a model, this one, and the opposite jaw, so that your occlusion is perfect. You then, after you've designed the crown, you design the implant, you place, sorry, you've given the purpose of the implant here to sit in the, to sit with access to the occlusal plane of the designed crown. You can then design again this surgical guide. The white is a designed surgical guide, which is designed here with examination windows here to examine, to make sure it is sitting properly. Okay, once you have that, you can then export it to a 3D printer of your choice, or mill it. If it is CAD/CAM data, which is imported back into the Sirona, you can mill it with the Sirona software, okay? Otherwise, you need a 3D printer. And then, of course, you need a surgical kit. There are surgical kits, special kits with special tools that you need to place the implant guide, okay? This is a cross-section, the features of one of the implants which we are introducing to the market, the Neodent. Here you have the surgical guide. This is the surgical guide, okay? And this is the sleeve, which is holding the drill, and the drill can only go in one section because of the sleeve, which is holding it, okay? The guided sleeve. So once you place it on, you start drilling, it goes one direction, okay? with depth guides here, depending on the implant length that you're putting in. Of course, these are some of the tools that you need. The surgical guide can come in with these sleeves, color-coded to match the implants, blue, green for the bigger ones, okay? These are dimensions of the drills, okay? There are 2 sleeve positions. Again, that will be much easier in the hands-on, depending on the situation that you are going to be doing, okay? So no unnecessary tools, extra hand. So you have here the guide here, you have the sleeve, and the drill is passing through. You can see the drill here. Or you have a drill key here. So either way, the key may be changed and you drill the implant, goes in quickly and easily. You have standard sleeves, narrow sleeves, again, depending on the situation of the implant that you're placing. Okay? The first section of the view. Can that person mute, please, who is opening doors? So basically, how do you go about placing an implant guided? You have your surgical site here. You prepare your surgical site by drilling through the soft tissue with a soft tissue punch. Then there's the initial drill. Then there's the second drill, which goes through the cortical bone. And then the osteotomy drills, which are different sizes depending on the size of implant. Oh, shoot. And then the implant placement. Now, you have 2 choices. You can drill surgically, the implant site is ready, remove the surgical guide, and place your implant freehand. That's guided drilling, but not guided placement. Or you place your implant guided, that means you drill with a guide and you place your implant through the guide. Those are some of the drills. I mean, so there are different sequences, but always very, very important to ensure that the engagement of the drill with the sleeve, because that's your guide. If you just need a 1 minute twist, sorry, a 1 degree twist of the drill, and your implant will end up in a different position, or it may end up attacking the neighboring teeth, depending. Okay? So it is a very safe, the safety has been documented. I don't want to bore you with that. Those are some of the journals, but this gives you a good example. When I was in the University of Pretoria doing my diploma, we had a case, and this is a cross-section of that particular case. The implant was being placed beyond the nerve, which you can see there. But because it was guided, we were able to, the professor was able to do the implant and it went in past the nerve. The next day we thought, you should have seen everybody's faces during the surgery. We were worried that there was going to be nerve damage. But the next day, the implant was perfect. When they took the PA, the implant was way past the nerve. So fantastic dentistry occurs. So everything under one roof, you virtual plan, you have your implant, and you have a guided temporization. Those days are here. Immediately, in less than 20 minutes, without taking another impression, you can do it. As we did for this lady. This lady, unfortunately, was attacked. This was one of my first cases done 2018. She was attacked and bitten, and she lost this tooth. These were the pictures before. And so a few days later, I don't remember exactly, she came in and we did guided implant placement. 1 visit, straightforward, 20 minutes with temporization. The implant is placed. This is the temporal abutment, and we restored it. You cannot see the acrylic here. This X-ray I took a few days ago, just a recall visit. Yesterday, actually, as a matter of fact. you can see the finer impression. We're able to temporize the implant. The patient walked out immediately with the crown. This is the same case before, after, before, after. Look at the soft tissue. Most of the time, if you draw the line, the soft tissue ends up going upwards. We lose soft tissue when there is loss of tooth structure. This picture was taken yesterday when we did the recall visit, when I was preparing for this. So the soft tissue, when she smiles, there's very good restoration. Now you may want, this is the same case, and you may want and say, Dr. Tom, if you see here, it's showing the dent. Dr. Tom, you are tricking us. This is not the same case. It is. Why is the picture like this? Because this picture was taken a reflection with the camera. I'm sorry, the mirror in the mouth. As you see here, screw retained. There was some bit of dimensional loss at the time, and it is pretty stable. That's the cross-sectional view. And she's been okay up to date. This is a case that I did. Unfortunately, the slide is before. Let me go to the very beginning. So this was supposed to be the first slide. I was placing an implant there in that side. So you're gonna see me practically doing it. I did this on Tuesday. So there's my surgical guide. We had planned to do 2 implants, but I decided to do 1 because of the defect. There's the surgical guide in place. This is the place where we are placing the first implant. This is the access examination windows, examination windows to examine whether my guide is fitting properly, and it was fitting properly. Okay? So in a few minutes, I'll get done.
This is a tissue punch.
That's the drill, the one for drilling away the gum.
Sometimes we have to use the drill extender.
In that case, I use, oh, shoot, yummy. Sorry. So you see here, I'm replaying. This is an extracted site. That's where we are placing the implant. This one I extracted a few days ago. There was infection. So I waited for the infection to be reduced before I risk it spreading to my implant site.
Make sure the surgical guide is fitting.
Place it in.
Make sure it is fitting. Then we check for
the examination windows.
Inspection windows.
Or inspection windows.
Fitting properly. Fitting properly.
Yeah, make sure the guide is fitting properly, sitting properly, tight against the teeth.
Okay. First thing we do is get a tissue punch.
Get the tissue punch.
Use a tissue punch. This is a tissue punch. So
that's the tissue punch.
Punch the hole in the gum.
So there, because the tissue punch is not going far, you use a drill extender. The tissue punch. You feel I hit the bone. Until you hit the bone. Coming out. So, remove the surgical guide. Then remove the surgical guide. Now notice you use the metal suction there at the osteotomy site. As you can see, the tissue punch, the area where you punch, use a different suction for the back, for the tongue.
It have more than one section. You can see where the tissue pump has been. You can see where it has cut away.
So you can remove the tissue there. So you are removing the soft tissue in the area that you are going to place the implant. So there is the soft tissue. Then you put back the guide, of course.
Guide.
So there is the surgical kit. You have different types of surgical kit. A kit costs alone, that kit is about 3,000 US dollars. So you start with the initial drill. That's the initial drill.
There are different sizes depending on the size of implant.
Okay.
Then you start with what they
So
call
you put it in. That's the initial drill, the very first drill. You never ever jump drills. And that one engages direct. In this case, the drill engages direct the guide. And you drill in, out, of course.
Then you run. Sometimes you have to keep more.
You make sure it fits. There's a groove there. Right, if you look carefully in your sleeve. The patient was feeling pain, so I had to give anesthesia. He's still feeling pain.
Given anesthesia already.
If you can hear the comment because of the prior anesthesia, but the drilling was uncomfortable. So you have to watch your sterilized stuff because you want to make sure you see the water going down.
Here the drill
Okay. You see the bone. Okay, that groove is the one I'm talking about, which engages the drill. In this case, the bar engages the drill. Okay, so we start with the number 7.
As you can see,
very easy. No intraoral X-rays during the surgery because we've already planned. We already know where we are going. So it saves us time.
sometimes I see anesthesia inside the system.
You're still feeling pain, I gave it in direct in the osteotomy side. Any suction? The next one is for the surgical side. Training? Training down? Good. So that's the second drill. The other one was the initial drill. The second drill is going up to depth. And it is sitting in the groove. There's a groove. The bar has the vertical stop there. As you can see there, there's a vertical stop on the drill. So you go to the next number 2x7. It's a 2x7 drill, 2 millimeter by 7 millimeter long, 2 millimeter wide. So it goes. That one almost just falls in, but it gives a good direction of the path. Okay. So the next drill, putting the drill sequence 2x8.5. Then you drill the number 8.5, 2x8.5, 2x10. So we are increasing and getting up to the depth. That's it. Finish. Then we start increasing the width after increasing after 2.5 by 10. Then you go to a 2.5 by 10. So you are placing a 4 by 10, if I remember right. 2.5 by 10. Two 2.8 by 10 is the next drill. You can see the 2.8, drill the right direction. And 3.3 by 7 was the last drill. And we didn't go the whole distance. So you expect your osteotomy side. And we irrigate into the osteotomy side to remove any debris in a soft tissue which may have floated down there. The surgical guide. Put back the guide to place the implant guiding. At that point, you can even do it by freehand, but remember you build bone, which is soft sometimes, and you can end up with your implant going a different direction, part of least resistance. The speed of the move. So that's the implant driver. There, that's the implant driver. You make sure it is rotating very slowly, as you can see there, very slowly. You can see it is turning very slowly. Right there. Get the implant. And you point the implant up so that it doesn't fall down. You never let it point up. You never let it point downward. So you always make sure it is pointing up when it is on the implant driver until you're going in. With no water, you let it rotate and it goes in and in and in. As you can watch there, it's going in, almost disappearing. The implant driver is almost disappearing. It's rotating very slowly. There's just a drop of water there, which is giving reflection like it is rotating speedily, but it is not. Get the torque range. There's no pain now. So get the torque range. The torque it. There's an indicator where to stop, again, depending on the implant system, the surgical kit that you're using, it gives you where to stop. So the implant, the torque range, this driver is out, the implant is still in place. Take it out. The implant is in the osteotomy side. You can't see it easily. The mesial one. So we check an X-ray at that point. Now I'll go back to, this is the video of the X-ray, which we took. X-ray, you see the implant is parallel to the neighboring tooth. Okay? The angle does not do justice. It is not that close. It's because of the angle of the X-ray. But it tells you Yes, you are deep inside. You have to poke it more to bring it under bone. And this was the first video which I clicked on. That gives you, that after the placement, you can, oh shit, come on. There. There's the implant. We are talking it further now. We've already talked it as before. We're trying to see the angle. We have to tilt the video. I don't want to switch it now. Make it horizontal, then you'll see it. Tighten it to make sure we didn't pull it a little bit when you are coming on. There we go. So next we put a healing cup, and that's it. So this one. So behind here, the site is not good for implant placement. The lady is traveling out of the country, so she wanted something put there in the meantime. When she comes back, we place another implant at the back. Healing abutment is going in. Thank you. So, questions? Hello? Have I been speaking to myself?
Hello, Dr. Tom. Edward here.
Yes, Dr. Edward.
Thanks for the presentation. It's quite impressive. There has been a trend of digitalizing and from, of course, CAD/CAM, and then to surgically guided implant placement. And all of a sudden, I'm seeing impressions back into the workflow. Could we be going back to the original dentistry where we have to take impressions at every treatment planning that we plan, that we do? Because there's a time when the school of thought was that you could do with impressions and everything is digital. But I think in this treatment workflow, that an impression in silicone is almost indispensable. It's quite important to merge the impression with a CAD/CAM, with a 3D. So is it that we are now going back to impressions once again? Thank you.
Now, I will tell you, maybe I answer the questions as they come. Yes, I understand the comfort with taking a physical impression, but I will tell you the level of accuracy I have personally received is by using digital impressions. When I'm going to place an implant, when I'm planning to place an implant, I always, as a rule, digitalize the impression direct from the patient's mouth into an STL file. Saves impression material, impression trace, stone, plaster, you name it, and time. And the merging of the two has been very accurate. All the guides, and we've made many over the last 3 years, many guides. As I've told you, me, I don't do guided and non-guided implant placement. I have colleagues who I invite, I say, this patient, non-guided, here you are, handle. I don't, personally. Because I find it less stressful for me, less stressful for the patient, less chair time. As you saw, that case, I took 15 minutes in spite of talking. If I was doing check X-ray, drill, check X-ray, position, stop, I would have taken longer, even given my past experience with implants. So impressions For planning of guided, we prefer digital, direct from the patient's mouth. If you want to spend, and you see, in this case, we are talking millimeter dentistry. I don't want you to take an alginate impression. You've got to take a polyvinyl siloxane impression. These materials are expensive. You can scan, you can take your impression, bring it to us, we'll scan the impression without having to pour it, and we still make a model for you out of the impression. That's another way. But time as well and cost. We are trying to save you the time. If you send the patient on a non-busy day, we'll scan them for you if you are making the time. When I'm taking, when I'm doing the restoration, part of the process, because of the emergency profile of the implant, I found taking a physical impression very useful for the lab to give me a better crown with a better emergency profile of the gum at the gum level than doing it digital. We still can do digital. Part of the answer also comes with the level of expertise both of the dentist, your lab technician. It's possible to do non-guided, but you need a higher level of accuracy. I hope I've answered the question.
Yeah, thank you. Yes, you've answered.
Any other questions, guys? Am I alone here?
There's a question.
Hello, Dr. Tom.
Yeah.
Yes, thank you for the presentation. I'm just inquiring the feasibility of guided implant placement on knife edge ridges.
If you have a knife edge ridge, implantology states, of course it's possible, but even if you are doing it non-guided, the same basic principle apply. Number one, you have to have a table. You cannot put a plate on a table. Sorry, you cannot put a plate on a knife edge. So the first thing to do is to section part of the bone, okay? If you want to go down that route and create a flat platform where you restore. Or if you're going to graft, so it's theoretically possible to drill straight into the knife edge. But you've got to be very careful because the drill can slip on either direction. Even with the guide, you've got to be very careful. You remember drills go into the direction of least resistance. So either way, it is always important to create the platform. It's a flat surface. So maybe chiseling part of the bone is one trick. Because if you don't, either way, when you place your implant, that thin plate is going to go because of lack of blood supply. You need a minimum thickness. I hope that answers. I think if you are placing implants and you have not yet placed that many, I would rather you do it with an experienced hand. We have several periodontists. They can advise you how to handle that situation.
Thank you, Dr. Tom.
Or you come to me and we look at it case by case. Depends on where, is it in the prosthetic, in the aesthetic zone? Do you want to preserve? So there are so many other considerations. Any other questions, guys? And as you reduce your thin slice to a level which you're comfortable, you know you are losing height, physical height. So if you're especially in the aesthetic zone, one has to treat very carefully. And unfortunately, that's where you have more knife edges because of the dimensions in the anterior region compared to the posterior. If I may ask, have I been clear? Have people understood? Question, now chat, where? Where is the chat? Chat, oh, there are several questions here. I've just clicked on chat, sorry. Let's see, let me go. I was paying attention, where do I go? I want to start at the very top. Good evening, Dr. Tom, everyone. Good evening, colleagues. Are you able to increase volume? Sorry, I've just seen that. Whew. Okay. Your voice is very low at the moment. Can't hear a thing. Use earphones. Thank you, Dr. Tom. How's guided placement? With knife edge, I've answered that. Is your lab doing? Okay. My lab is already doing guided implant placement. In which do you need to scan the whole arch or the opposing or only a few teeth? It is best to scan as many teeth as possible so that you have accuracy. Not necessarily to scan the whole arch, that's number one, but the more teeth, the better. If you are doing on both sides, of course, you've got to scan both sides. That's number one. Two, you need to scan the opposite jaw so that during the prosthetic planning in the 3D phase, the prosthetic that is planned they take the care of the occlusion as well. That means your 3D also, if you can, especially to rule out other pathologies elsewhere, to take for the whole jaw. My volume was at maximum, by the way, so there's nothing more I could do. Good presentation. Training, we'll come to that. Thank you for those who said. So we've partnered with Stroman to try and make guided surgery more available in Uganda. Guided implant placement. There's a new implant we are launching. It's called Neodent. It has a Stroman surface. As you know, Stroman surface is one of the well-known surfaces. An implant kit ideally goes for $3,000 US. The implant kit alone. There are few lucky people who have either booked, or if you book early, there's just now only one guided surgical kit remaining. All you need is to buy the implants, and not many of them, only 10 of them. Each comes at a good price, and so you'll be ready to start your implant training. For those who are interested, please let me know. That is one. Of course, having the kit and the implant is not enough. You need to be able to be comfortable to know how to use the guided kit, to know more about the implant. So we start with the implant on the 10th of April. That's the second Saturday of April, I believe. In the morning, 8 o'clock, there'll be a presentation on Neodent implant. The type of implant, its placement, etc., its features, so that you understand. Then for those who will have acquired the guided kit, we will be able to support you by the training itself. And if you buy 10 implants, you get your free guided kit. Or if you buy 10 implants, you can get a non-guided kit. Okay? Now, there's still one more here. I'm trying to see. I see in the chat question. Dr. Antulume, you can text me your question because I don't see. Either you raise your hand with, I suppose you have to raise your hand. So then you can be picked, you unmute and pick. But to go back, so I'm going to stop the chat since I can, so I'm going to stop the chat because it is disturbing me. Okay. There are opportunities to do guided when you buy in with a kit. If you're not comfortable to buy and you just want to try, you can either try it at one of our branches. All our branches, we have access. Hello. Can you mute, Mr. If you are? Hello. Can you mute? Okay. So there will be opportunity for doing guided at any of our branches. There will be one kit available for hire. And so we are trying to meet all the needs of the market depending on your circumstances. So, yeah, we'll try and find a middle ground. But if you buy the implant, this guided kit is specific for an implant. And the drills can hopefully be used for that one. But I guess, Magezi Maganda, you can try your tricks. Drill with one drill kit and then place another implant. We are not responsible for the after effects. Another question? Dr. Antulume, you can unmute and ask your question direct, Sebo.
You already answered my question. It was about the need to scan both jaws.
Okay, so it's the one here. I see it. Okay, it's best to scan both jaws if you want a good digital planning of the occlusion, because you may have a supraerupted tooth, and so you've got to plan for it occlusion, the prosthetic space. Another question? I see one more question. What is the cost implication? Well, it depends on cost implication of what? Initially, because Toman is trying to encourage you to switch from wherever you are, there are very few kits. Eventually, you're going to have to buy those kits. So early start, you save money. And I tell you, there's only one remaining, one surgical kit. For those who want to buy direct and have your own. Otherwise, you'll end up hiring the one which will be on hire at the office. So come to one of our branches. We'll try and make it easier. So if you have any interest, please register your interest with me, inbox me, and say I'm interested in XYZ, and we try and address your needs. Any questions about implant placement and surgical guide? Was it very clear? So remember the offers which are available just for your information. Pan Dental will digitalize all your models free of charge for the next 3 months. We ask for your support as a growing lab, because with your support, we can do more for you as dentists. There are already other free offers. If you, let's say, send 10 PFM crowns, you get 1 free 3D image for your patient of choice, for instance. If you do 5 zirconia, free 3D. We have an experienced team. We are ready to make dentistry easy and to make sure you can do more fantastic stuff for your patients. Moderator, advice. We are 120. Moderator, advice.
Thank you very much, Doctor. Hello.
Anybody with a question? We'll try and organize some hands-on with Stoman. You'll be, keep your ears on the ground, like they say. But on the 10th is the first one. And after that, you register your interest. The Neodent implant will be the cheapest implant in Uganda. That I promise. Question? I suppose you're all tired and we are ready to call it a day. Dr. Antulume, you want to say something? I see you're back.
Thank you very much, Dr. Tom, for the presentation. And thanks everyone for attending the CDE.
If you have another questions, you can post it on the on the group and we can share. It's not a problem. If there's anything that you didn't understand, please post it and we will be able to do our best. A luta continua, may your dentist get more fun. I suppose it is Kaheri. We meet on the chat group, on the WhatsApp group. I don't see any. Before I sign out, let me see if there are any questions in the WhatsApp group. Akuna.
Okay, doctor. Thank you very much.
Wait, yeah. There are no questions.